Thank you very much for that introduction, Dr. Chow. Welcome everyone to another edition of Echo Rounds. Today we're going to be talking about cardiac neoplasms. So a fairly rare diagnosis, but it's not something that we uncommonly encounter in the echo lab. And certainly when we do encounter it, it can have fairly devastating consequences. So I think an important topic to discuss, and hopefully after this talk, you'll keep this in the recesses of your mind and have that on your differential when somebody presents with cardiovascular symptoms. Oops. Our objectives today, we'll do an overview of benign, malignant, and metastatic cardiac neoplasms. We'll be discussing the clinical presentation, the treatment, as well as the prognosis. We'll talk briefly about how we establish a diagnosis and the advantages of echocardiography. We'll discuss some of the typical echocardiographic features of cardiac neoplasms, particularly the more common ones, and we'll review a few echo cases. On the bottom right, you can see a cardiac MRI case of a left atrial myxoma that's likely attached to the intraatrial septum, prolapsing into the ventricle and diastole. So quite a nice case. In cardiac MRI, we'll have some words on cardiac MRI as well. So starting off with our introduction, primary cardiac tumors are fairly rare. In a large autopsy series of approximately 12,000 patients, the incidence was only 0.1%, and they're often discovered incidentally when imaging, such as an echo or a CT scan, is organized for other reasons or vague cardiovascular symptoms. Thankfully, the vast majority, approximately 75%, are going to be benign, and myxomas are going to account for the bulk of these, about half. Despite their oncological designation of benignity, they are cardiac tumors, so despite the fact that they're labeled as benign, they can have fairly devastating consequences. So it's important to recognize them and diagnose them, do the various staging CT scans, and refer for surgery when appropriate. The malignant primary cardiac tumors, the majority are going to be sarcomas, rounded out by lymphomas and mesotheliomas. These are extremely tricky to manage because they often have an advanced stage on presentation, with the majority of individuals actually having metastases on their initial presentation. Detection can be challenging given the fact that they are rare. They're often not well recognized by various readers. Individuals can be asymptomatic, or they can have a host of non-specific symptoms which might be attributed to more common cardiovascular diagnoses, and the symptoms might actually be quite vague and mild. Management often isn't straightforward, and the treatment decision requires a thorough analysis of the potential benefits and harms of surgery. What I do want to convey is that metastatic involvement is going to be far, far, far more common. So if you see a cardiac mass, it's 20 to 40 times more likely to be metastatic from an extra cardiac primary than a primary cardiac tumor, if you will. Moving on to the symptomatology. So the symptoms can actually be classified into 4 broad categories. You can have constitutional symptoms, embolic symptoms, cardiac manifestations due to invasion, and metastatic disease. With respect to the constitutional symptoms, these can be symptoms that we typically associate with cancers: fevers, chills, rigors, weight loss, arthralgias, myalgias, lethargy. And this is often due to the fact that even benign tumors can release inflammatory cytokines, often a higher concentration when the tumor actually exhibits signs of necrosis. And the tumor that's notorious for this is the myxoma, which often secretes high levels of interleukin-6. Embolism is not uncommon. This can be either tumor fragments or thrombus, and the rate of embolization is going to vary depending on the tumor type, the friability of the intraluminal tumor surface, and the origin of the tumor, and whether or not the tumor is intramural or intracavitary. The common offenders are particularly villous myxomas, papillary fibroelastomas, hemangiomas, and lymphangiomas. When they do metastasize, they often go to the brain, And when they do go to the brain, in about 40% of instances, it's going to be affecting both hemispheres. But they can essentially embolize anywhere. The pulmonary embolism, particularly with right-sided tumors or left-sided tumors with an intracardiac shunt. You can have visceral infarction, limb ischemia, myocardial infarction, and certainly when they do metastasize, aneurysm formation is not something that's uncommon. The cardiac manifestations are going to be secondary to direct extension or mechanical interference of either a myocardial or valvular function. So you can have a host of valvulopathies. There can be an interruption of coronary blood flow, particularly when the tumor is invading or encasing a coronary artery. Interference of the conduction system can lead to tachyarrhythmias or bradyarrhythmias. Certainly, they can accumulate in the pericardial fluid, leading to constriction and tamponade. If they're occupying a good amount of the cardiac chamber, you can have evidence of restricted filling, and the patient might behave like a restrictive or a hypertrophic cardiomyopathy. The primary and malignant tumors, as I mentioned, are often going to present with metastases on the initial presentation, and these are usually going to be the lung, brain, and bones. So they might present with phony pain, neurologic manifestations such as strokes, focal neurological deficits, or seizures, or shortness of breath secondary to lung metastases or otherwise chest pain. The detection, so moving on to the diagnosis, detection is typically going to be by echocardiography, cardiac MRI, or CT scan, and echo has a number of advantages. It's dynamic, you have real-time evaluation, you can fairly confidently assess the entirety as well as the extent of the mass, as well as the hemodynamic consequences. The sensitivity is quite good, 93% and 97% for TTE and TEE respectively. Few disadvantage, you can have suboptimal image quality in about 10 to 15% of patients, has a narrow field of view, so often the extracardiac manifestations and extracardiac extension are poorly delineated. Artifacts can sometimes make it tricky to determine whether that truly represents a cardiac neoplasm or something that might be either a reverberation artifact or normal anatomy. And tissue characterization is actually not quite as good as CT or MRI. When establishing a diagnosis, a rapid establishment is key. A lot of these tumors can be quite aggressive. They can metastasize. They can have devastating consequences even in a short period of time. So when you do encounter an intracardiac mass, it's actually worthwhile expediting the investigations and making a few calls. Biopsy is still key. You might ask, it's an intracardiac tumor, there's no extracardiac extension, why don't you just resect it? With the advancements in chemotherapy and the various subtypes of tumors, some of them responding to immunotherapy, oftentimes neoadjuvant therapy is given. So it's very, very important to establish a biopsy, and involving the surgeon early on in the diagnosis is going to be key as well, because they might be able to get a biopsy for you, and it helps them plan their surgery as well. Oftentimes they'll require 3D or 4D reconstruction through CT or MRI before they actually want to open the patient up. Okay, so now moving on to our benign cardiac tumors. Over here, the classification is listed. Myxomas and papillary fibroelastomas are going to be your two most common, with myxomas easily being the most common. Rhabdomyomas, fibromas, teratomas, Purkinje cell tumors, and hamartomas, lipomas, paragangliomas are going to be rounding out the rest. And just a shout out to Dr. Connolly, who has an excellent tutorial on cardiac neoplasms. That's about a 20 to 25 page PDF document, which I highly recommend, and I got some of the information from that resource. Myxomas are going to be your most common benign cardiac neoplasms. They're about 30 to 50% of all primary tumors to the heart. They usually present within the 3rd to 5th decade of life and show a predilection to women, with 65% of cases occurring in women. Oddly enough, about 5 to 10% of these can be familial, so a consideration of screening of first-degree relatives is certainly prudent. Myxomas can also be associated with an autosomal dominant syndrome called Carney syndrome, where Carney syndrome actually accounts for 7 to 10% of all cardiac myxomas. It's also characterized by multiple tumors, endocrine tumors, as well as schwannomas. Important to note that with myxomas, they can recur following resection, and they can actually occur in multiple sites. The recurrence rate has actually gone down fairly significantly over the past few decades, and that's likely owing to an improvement in surgical technique and probable complete excision as opposed to partial excision in the past. They're referred to as benign, but what I do want to stress is that myxomas, particularly if they're villous in nature, can embolize and deposit along the arterial circulation and make their way into remote sites where they can actually have fairly significant consequences. The clinical presentation, the patient might present with obstructive symptoms, including presyncope, dyspnea, cough, or heart failure. They can embolize to virtually any organ or tissue, and they are often associated with constitutional symptoms, as I mentioned, likely due to a significant secretion of pro-inflammatory cytokines. The treatment is going to be surgical resection. The postoperative mortality is between 0 and 7.5%, probably more recently closer to the 0% figure, owing to also an improvement in surgical technique and early detection. Atrial arrhythmias and AV conduction abnormalities are common and can affect about 20 to 25% of individuals in the post-operative period, and about 3% of individuals are going to be having recurrence. So moving on to what we came here for, the echocardiographic features. They can be quite variable. 50% are going to have a globular or smooth surface. The other half are going to have an irregular, friable, multilobular appearance. They can demonstrate heterogeneous echogenicity with areas of echolucency and calcifications. They're fairly large, typically between 4 to 8 centimeters, and they can be up to about 16 centimeters. Left atrium is going to be the typical location by far, with approximately 80 to 85% occurring in this cardiac chamber. The right atrium is going to have about 10 to 15% of the myxomas. 1 to 2% can be biatrial, and 1 to 2% can be within the ventricle. And also important to note that they can rarely affect the heart valves directly. The vast majority are going to be solitary, greater than 90%, and they're generally pedunculated with a fibrovascular stalk attached to the subendothelial base. Usual site of attachment is going to be the interatrial septum in the region of the fossa ovalis. Now, the subendothelial base, that's important because myxomas do not invade the myocardium. So if you have an intracardiac mass, which is demonstrating infiltration into the myocardium, chances are that won't be a myxoma. The mobility on echo is going to be variable, and that's going to depend on the size as well as the width of the implantation stalk. As I mentioned, they can protrude into the AV valves during diastole. There can be an impairment in diastolic filling, causing mitral and tricuspid stenosis, which we can assess by color Doppler or continuous wave Doppler. They tend to have a fairly poor blood supply and are going to have partial and less than myocardial enhancement with contrast echocardiography. The differential diagnosis is going to involve thrombus and other cardiac tumors, such as a sarcoma or intracardiac metastases. So just a few still images of a left atrial myxoma. You can see that quite nicely here in the parasternal long axis, likely attached to the interatrial septum, although that's tough to see, and a few still images of systole as well as diastole, and you can see a large, compact, globular myxoma prolapsing into the ventricle during diastole. And so moving on to some TEE images. So this actually demonstrates some of the typical features of a left atrial myxoma, a villous left atrial myxoma. You can see that it's multilobulated. On the right, you can see that it's clearly attached to the interatrial septum. A little tough to see a stalk, but you can see periods, so you can see areas of echolucency as well. And owing to the mobility, it's easy to see how this could lead to tumor embolization quite easily. And And this here represents the other common subtype, a large, globular appearing, more compact myxoma. And you can see that it's clearly occupying almost the entirety of the left atrial chamber and prolapsing into the ventricle during diastole. So quite a nice example here. And over here is to prove that the myxomas aren't isolated to the left atrium. We see an example of something that was confirmed to be a myxoma in the right atrium on the four-chamber short axis and off-axis views. You can appreciate that on the right, there might be areas of spotty calcification as well as areas of echolucency. And on the top left here, we see injection of DEFINITY. You can see that the uptake within the right atrial myxoma is actually quite poor, certainly less than myocardium. As mentioned, they have a fairly poor vascular blood supply. On the right here, we actually have a TEE demonstrating a villous left atrial myxoma that's actually invading the pulmonary vein. So important to note that these can actually locally extend into nearby cardiac structures. And on the bottom, just a nice zoomed in shot showing a clear area of echolucency, some area of calcifications, and an irregular surface. So echo is actually quite good for establishing a diagnosis of myxoma. And if they have some of the typical features, you can be quite confident in your diagnosis. Moving on to our second most common primary cardiac tumor, the papillary fibroelastoma. Quite rare, 0.33% in one autopsy series. Doesn't really show a predilection for one gender or the other. The age of presentation is typically going to be within your 50s. Individuals are typically asymptomatic, but if they are symptomatic, the vast majority of patients will be presenting with embolic phenomenon, and that's typically going to be a stroke or a TIA, followed by a myocardial infarction. Half of symptomatic patients tend to have a cerebral embolic symptoms. In a study of 45 patients with a PFE on TEE, 6.6% actually went on to develop embolic symptoms within a year, so not infrequent. TEE tends to be the imaging modality of choice with a sensitivity of 89% and a specificity of 88%, and higher sensitivities and specificities for larger papillary fibroblastomas, which is quite intuitive. Treatment's a little bit controversial. It makes it easy if the patient's symptomatic and there's a residual papillary fibroblastoma, so just go ahead and take that out. If the individual is asymptomatic, things that would lead you down the route of surgery are if the papillary fibroblastoma is large, if it's mobile, and it has the presence of a stalk, and the patient is otherwise a good surgical candidate. And the surgical technique is typically going to be tumor shaving of the valvular leaflets and either reconstitution or replacement of the valve. Observation is reasonable in this scenario, particularly if they're small, asymptomatic, they're non-mobile, they don't have a stalk, and the patient prefers not to undergo surgery or is otherwise a poor surgical candidate. The prognosis is excellent after surgery, and there's virtually no risk of recurrence. With respect to the echocardiographic features, the mass itself might have focal calcification and occasionally cystic degeneration. It has the appearance of being firmly attached to the valvular or mural endocardium, and these masses are avascular. They can be round, oval, irregularly shaped, but they are typically well demarcated and fairly homogeneous. They're often compared to a sea anemone due to the numerous and delicate papillary fronds that they typically have. The vast majority, 80 to 90%, are going to be on the valvular endocardium, with the aortic valve being most commonly affected, approximately 37 to 45% of the time, and the either side of the aortic valve can be involved. The valve that follows in frequency is then subsequently the mitral valve, in which it's usually present on the ventricular side. Despite their affinity for the valve, they tend not to lead to any significant valvular dysfunction or stenosis. They're often solitary, but 2 to 8% can be multiple, and usually approximately about 1 centimeter, with the vast majority being less than 2 centimeters. And as I mentioned previously, 40 to 45% can actually have a small stalk, and the stalk serves to make it more mobile and more likely to embolize. So a feature that you can use to inform your decision about whether or not you'd like to proceed with surgery. And this here is just a couple pictures of AC and anemone. The differential diagnosis is going to be a myxoma. A large Lambos excrescence can sometimes be difficult to differentiate from a papillary fibroelastoma, a thrombus, or otherwise a valvular vegetation. And so 2 examples of a papillary fibroelastoma here. We can see the mass firmly attached to the aortic valve and the peristernal long axis here, as well as the 5-chamber. As you can see, although it's fairly large, about 1 centimeter, it's not really significantly impacting the opening or closing of the valve. So really don't lead to much in the way of valvular dysfunction. And a couple of nice shots of the papillary fibroelastoma in short axis here. You can see that it's quite a well demarcated mass. It's fairly homogeneous, and again, not really causing much compromise in the opening of the aortic valve. Okay, so moving on to our third benign cardiac tumor, the lipoma. Just a point, a lipoma should be differentiated from lipomatous hypertrophy, which is a deposit of fat in the interatrial septum at the level of the fossa evalis, typically when it's greater than 2 centimeters. Lipomatous hypertrophy in itself is actually a bit of a misnomer because it's not necessarily hypertrophy of the adipocytes, it's an increase in the adipose cells. And lipomatous hypertrophy is not something that's encapsulated and not truly a neoplasm. So it's actually incorrect to call it a cardiac neoplasm. Lipomas, on the other hand, can occur sporadically. They can occur in all ages and tend to occur with an equal frequency in both sexes. They're often asymptomatic and discovered incidentally. Typical locations will be subepicardial and subendocardial. The subepicardial location tends to be asymptomatic, but when they get large, they can lead to a pericardial effusion or chamber compression. Subendocardial locations can interfere with the mechanical function of the heart or the valve and lead to heart failure type symptoms. Treatment is surgical and the prognosis is fairly excellent. The echocardiographic features, unfortunately, are fairly non-specific, so it's hard to definitively call a cardiac mass a lipoma. They can occur in any atrial or ventricular surface. As I mentioned, usually subepicardial or subendocardial. The subendocardial location can be pedunculated or grow as broad-based masses. They might display calcification. If present in the pericardial space, they tend to be hypoechoic and hyperechoic, particularly if they're intracavitary. Given the fact that echo is non-specific, CT and MRI are going to be extremely beneficial with lipomas. CT is providing better tissue characterization, low attenuation with a homogeneous appearance, and cardiac MRI demonstrate an increased signal intensity with the T1 weighted sequences, and you can actually do fat suppression and fat saturated sequences as well to definitively make the diagnosis and obviate the need for a biopsy. Typically quite large, between 1 and 8 centimeters, and usually single, although you can see multiple lipomas in the setting of tuberous sclerosis. So quite a nice example of a TEE demonstrating a cardiac lipoma in the right side of the heart. You can see that the mass is fairly large, broad-based attachment. It's homogeneous and actually causing compromise of the tricuspid valve, probably leading to some degree of stenosis. But you can see that, this doesn't necessarily, clinch the diagnosis of a lipoma. I mean, this could just as easily be a sarcoma. It could be an intracardiac metastasis from another primary. It could even be a myxoma. So your cardiac MRI is going to be quite beneficial. And over here, I've given an example of an intracardiac tumor, a right atrial myxoma. You see on the top left, it's actually within the right atrium attached to the interatrial septum. And with your T1 weighted sequence, you can see that it actually demonstrates a uniform hyperintensity in the right atrium, as well as the parts of the interatrial septum, and actually has a signal intensity that is identical to the subcutaneous adipose tissue. On the bottom here, we actually have T1 and T2 weighted sequences with fat suppression. And you can see with the fat suppression sequences that the right atrial mass actually demonstrates fat suppression both on T1 and T2. So with the various sequences, if lipoma is on the differential, a cardiac MRI can actually pretty confidently clinch the diagnosis for you. Okay, moving on to our fourth cardiac tumor, the fibroma, which is the second most common cardiac neoplasm in children. It can be associated with Gorlin syndrome, an autosomal dominant condition associated with basal cell carcinomas. Tends to have an equal frequency in both sexes, usually slow growth with a low recurrence rate, and individuals are often symptomatic, with only a third of individuals being asymptomatic. Now, when they are symptomatic, they present fairly impressively with ventricular arrhythmias, AV block, heart failure, as well as sudden cardiac death. The treatment of choice is going to be surgical resection, and CT or MRI is critical preoperatively to determine resectability. On the bottom right, we have a nice example of a cardiac fibroma in the left ventricular apex and the intraventricular septum, showing identical intensity to the surrounding myocardium. Moving on to the echocardiographic features, they're going to be solitary, they're very homogeneous, it's an echogenic lesion. They're typically located in the LV free wall, the ventricular septum, or the apex. Having said that, in less than 10% of cases, they might be found in the left atria or the RV. They're well demarcated from the surrounding endocardium, typically by calcification. They can grow into the LV cavity and be quite large and interfere with filling. The average size is 5 centimeters, but they can be as large as 10 centimeters. So a really nice example of a cardiac fibroma that's attached to the left ventricular free wall. You can see that it's well demarcated. It has identical signal intensity to the myocardium, although tissue characterization is not as good with echo. There might be a small pericardial effusion. You can see that it's quite homogeneous and large. So when you see a mass like this, a cardiac fibroma should be on your differential. And so moving on to teratomas, they are extremely rare. The reason I brought them up is because although they're generally benign, they can have malignant transformation and can have a risk of infection. They're often found within the pericardium as a large mass or a multilocular complex cyst, often multicystic, and can vary significantly in size to being very small, less than 1 centimeter, to very large, greater than 15 centimeters. They're often smooth but can be lobulated, and mature teratomas can have well-differentiated elements, including bones, cartilage, muscle, connective tissue, and nerves. They often present during the second and third decades of life and have a slight female predominance, and individuals are usually asymptomatic. And once again, surgical resection is going to be the treatment of choice given the risk of malignant transformation and infection. And so a nice example of a teratocarcinoma on TEE here, you can see on the left that it is going from the pulmonary vein into the left atrium. There's areas of calcification. It's well demarcated, as well as areas of echolucency. Tough to see whether or not there's any intraneoplastic vascularity. There might be a few specks of blood that we can see here, or that might just be the pulmonary vein itself. And on injection of DEFINITY contrast here, you can see that really doesn't opacify all that much, so likely suggesting that this is not a well vascularized tumor. So you can see that if you don't have the typical multilobulated cystic characterizations, it can be a little tough to clinch the diagnosis, particularly when there are no mature formed elements. So additional diagnostic testing is often warranted. So just quickly, the other benign cardiac tumors that you want to have in your differential, these are a lot rarer, but include rhabdomyomas, which all occur almost exclusively in children. 80 to 90% of cases are going to be associated with tuberous sclerosis. There usually going to be multiple tumors found on the ventricular walls or the AV valves. They regress spontaneously and surgical resection is not required. Paragangliomas, they're extremely rare. They can be functioning and secrete catecholamine. So individuals can have typical symptoms that would be suggestive of pheocardiomyosarcoma. They're very vascular and often involve the coronary arteries. The reason I put this in here because they have a typical location. They're usually large and along the posterior wall of the left atrium or the left atrial roof. They can also arise from the interatrial septums and can be along the coronaries. They often have a broad base of attachment and typically are seen in adults between 30 and 40 years of age. Lastly, hamartomas, which are rare polypoid or cystic masses. They're typically in children under 1. If they do present in adults, the average age is 35. Slight male predominance can be associated with tuberous sclerosis and usually arise on the ventricular free wall, followed by the RA. Okay, so moving on to the second aspect of our talk, which are malignant cardiac neoplasms. They represent approximately 15 to 25% of all primary cardiac tumors. Half to three-quarters are going to be sarcomas, with mesotheliomas and lymphomas rounding out the rest. Very important to note that when you actually diagnose an intracardiac mass as a cardiac sarcoma, you have to be cognizant of the fact that this might actually represent a metastases. And the reason I say that is that because virtually all sarcoma subtypes have been reported in the heart, the most common of which are the angiosarcomas, the leiomyosarcomas, fibrosarcomas, and rhabdosarcomas. So critical to do a comprehensive physical examination and your staging CT scans. The histological subtype is probably less important than the histological grade and the presence of metastases. And the histological grading, what's going to be important is the amount of mitotic activity, whether or not there's necrosis, and whether or not there's cellular differentiation. Highly aggressive sarcomas are highly aggressive. They demonstrate a highly infiltrated pattern of growth. They often occupy most of the effective cardiac chamber. And cardiac MRI actually provides excellent tissue characterization. So this is one of the cardiac neoplasms where you may want to consider actually getting a cardiac MRI. Angiosarcomas are going to be your most common primary cardiac sarcoma, between 30 to 37%. They're usually within the ages between 30 and 50 years of age. There's a slight male predilection, and unfortunately, they present with advanced disease during the initial presentation, with about 2/3 to 89% of individuals having metastases at initial presentation, either to the lung, liver, bone, or brain. Symptoms include dyspnea, chest pain, constitutional symptoms, and congestive heart failure. Important to note that can be associated with an SVC syndrome and are commonly associated with hemopericardium, which likely suggests intramyocardial infiltration. Poor prognosis with a mean survival of 9 to 10 months, and treatment is quite comprehensive with surgery, radiation, adjuvant and neoadjuvant chemotherapy, as well as immunotherapy with interleukin-12 analogs. The echocardiographic features, these are often going to occur in the right atrium. I believe the vast majority of cases are within the right atrium. As mentioned, they're going to have pericardial involvement, so look for a hemorrhagic pericardial effusion. They can invade the cable veins, leading to an SVC syndrome, as well as the tricuspid valve. So these are the features that you're going to be looking for on an echocardiogram when you're suspecting a sarcoma. they can have invasive, irregular, and broad-based nodular appearances, and can actually form vascular channels as well. So quite a nice example on the bottom left, and an echocardiogram demonstrating a cardiac angiosarcoma. You can see that it's occupying quite a lot of the right atrium, involving the right atrial free wall, going into invading the tricuspid valve, as well as the right ventricular free wall. This individual did actually have a hemopericardium, but this was restrained before this echo was done. And quite a nice cardiac MRI, which demonstrates similar features to the echocardiogram. You can see that the signal intensity is very similar to the surrounding myocardium. It's, invaded the tricuspid valve as well as the right atrial free wall. So cardiac MRI, really quite beneficial in the setting of a cardiac sarcoma. This is a TEE of a cardiac sarcoma. This is one of the rarer subtypes. This is a cardiac intimal sarcoma, which is demonstrating mobility and prolapsing within the left ventricle in diastole. You can see that it has an irregular surface with multiple cysts, possible calcification, and it's quite heterogeneous and likely has some degree of embolic potential. So the cardiac sarcomas, particularly the weird and wonderful subtypes, can actually have quite a complex appearance. Finishing off with cardiac lymphomas are malignant primary tumors. These are going to be 1 to 2% of the primary cardiac tumors, often found in immunocompromised individuals. There's been an increase in frequency in recent years due to an association with HIV and post-transplant lymphoproliferative disease. The average age at the time of diagnosis is going to be between 62 and 67 years of age, with a slight male predominance. They usually involve the right heart in 75% of cases, and 2/3 of the time are going to present as a single lesion. 50% of cases are going to be associated with pericardial effusion, and they're often quite large, with a mean size of 7 centimeters and up to 12 centimeters. 80% of individuals that are immunocompetent are 80%, are going to be of the diffuse large B cell subtype in immunocompetent individuals. Despite the fact that they're chemotherapy sensitive, there's a very poor prognosis, with 60% of individuals dying within 2 months. Radiation and rituximab therapy can be considered, and rituximab, our CD20 analog, has actually improved survival within recent years. Okay, and the last part of our talk, which will be metastatic cardiac neoplasms. And as I mentioned previously, these are by far the most common neoplasms of the heart, up to 20 to 40 times more common than primary cardiac tumors. In an autopsy series of 1,900 patients which were dying of cancer, 8% of these individuals actually had evidence of cardiac metastases. So we're likely missing out on some cardiac mets when we're treating our patients with cancer. You need to have a high index of suspicion, particularly in individuals that do have cancer and new cardiovascular symptoms. The route of spread is going to be important in determining your differential when the cardiac mass is actually the first incidental finding. There can be hematogenous spread, direct invasion from the mediastinum, tumor growth into the vena cava, and extension into the right atrium, as well as lymphatic spread. The most common metastatic cardiac neoplasms come from the lung, followed by breast, lymphoma, and leukemia. Hematogenous spreads are typically going to be melanoma and mesothelioma. Lymphatic spread, leukemia, lymphoma, and mesothelioma. Direct extension is going to be by far lung and breast. Venous extension is typically renal, but hepatic extension into the IVC and right atrium can also be seen. Echocardiographic features. Mets are almost always found in the pericardium and associated with a pericardial effusion. That's going to be the most frequent finding. So if there's a pericardial effusion, which you don't necessarily have a good etiology for, certainly consider malignant pericardial effusion. When you are doing an echo, you need to interrogate their surrounding structures to assess if there's evidence of direct extension from a lung tumor, whether or not there's a lung metastases that's invading the heart. And if it's extending from the IVC into the RA, you might want to consider renal cell carcinoma or hepatic carcinoma on your differential. So this represents a lady that actually had a history of melanoma and unfortunately had recurrence with intracardiac metastases. You can see a large net in the right atrium and possibly in the interatrial septum as well. And it's illustrated quite nicely in the subcostal view. This is an individual that had a hepatic cancer, and you can see on the bottom left here that the malignancy is actually invading into the IVC, going into the right atrium, and you can see quite clearly on the four-chamber, the short axis, and the RV inflow views that there's a clear right atrial mass. But what really clinches the diagnosis is the subcostal shot, which shows the direct extension. So oftentimes associated with a renal cell carcinoma, but not uncommon to have a hepatic tumor invading into the right atrium via venous extension. On the left here, we have a lady that had breast cancer with a significant amount of tumor invasion into the LV apex and the LV free wall. You can see that there's a pericardial effusion as well as a pleural effusion, and certainly some evidence of RA inversion. This individual on the right had lung cancer, and you can see that there's actually an extensive amount of tumor infiltration into both atria as well as the interatrial septum. Also an individual with lung cancer which has invaded into the right atrium and the interatrial septum. You can see that quite clearly here on the left, and there is certainly some evidence of obstruction of cable flow, so not uncommon to see why these lung cancers can be associated with venous compression as well as SVC syndrome. So just a quick note on pseudotumors as well as other cardiac masses. To differentiate between cardiac neoplasms and pseudotumors, clinical context is going to be key, and that's going to help you. Unfortunately, the cardiac tumors can be asymptomatic, so really when you're doing your echo, it's critical to use multiple and non-standard echocardiographic views using different imaging modalities such as CT, MRI, and employing a TEE when the diagnosis is in doubt is going to be important. You need to have a strong knowledge of normal anatomy, variants of normal anatomy, as well as artifacts, and not a bad idea to have another set of more experienced eyes when you're looking at an echo, particularly if you might not know what it is. And certainly for the learners, no shame in asking for help. Pseudotumors and other cardiac masses that can be mistaken for cardiac tumors include thrombus. What will help you is that if it's in the atrial appendage or the LV apex following myocardial infarction, TEE, definity contrast can be beneficial, as well as the clinical context, whether a patient has atrial fibrillation, mitral stenosis, akinetic aneurysmal or dyskinetic segments. Infective endocarditis, we know that this is going to be an independently mobile mass. The patient will have clinical signs and symptoms of infective endocarditis. It's typically on the low pressure side of the valve. There might be the presence of an abscess. Non-bacterial thrombotic endocarditis, typically along the lines of valve closure, usually symmetric with smooth or verrucoid, otherwise warty textures. The aortic valve is most commonly affected, followed by mitral valve, tricuspid valve, and pulmonic valve. Valve excrescences, thin, less than 2 millimeters, long, greater than 3 millimeters, with an independent undulating hypermobility, usually along the line of closure of the leaflet on the atrial side of the mitral valve and the tricuspid valve, and the ventricular side of the aortic valve. Less common, mitral annular calcification, particularly if caseous mitral annular calcification presents as a large, round, echo-dense mass, smooth borders with a central area of echolucency, usually along the posterior mitral valve leaflet. And lastly, blood cysts. Cysts, something that we don't commonly think about. Blood cysts can be in the endocardium along valve closure lines. They can be thin-walled. They can also occupy the AV valves. Pericardial cysts are going to be small, rounded. They're going to be echolucent mass, usually found adjacent to the right atrium, often asymptomatic, but may lead to cardiac compression if they get very large and are associated with an excellent prognosis. And finally, just to wrap up, a plug for 3D echocardiography. I encourage everyone to consider this because it can give you a more accurate assessment of cardiac mass volume. It allows you to scan the entire mass to assess homogeneity, calcification, necrosis, vascularity, and point of attachment. You can get a detailed assessment of the tricuspid valve as well as evaluate normal variants. Allows you to differentiate thrombus from myocardium and can give you a detailed assessment of LV non-compaction as well. So that concludes my talk. Thank you very much, everyone, for coming. It was quite a lot of information, but I hope you found at least some of that beneficial, and I hope that you enjoyed the cases that I selected. And for the basketball fans out there, hopefully you're enjoying some of the preseason games.
So thank you very much, Sikander, for this wonderful talk. The visuals are really beautiful. Thank you, Sikander, for this talk and also for the beautiful visuals. And I have one quick question.
Sorry, Dr. Chow, you're breaking up. I didn't quite catch that. Hi, very much.
Yeah.
Questions.
Okay. I can also see you like that. Take this one.
Sikander, it looks like we've lost Chi Ming. So maybe just to open it up to other folks for questions for Sikander.
Sure, like, I don't care.
I guess one comment I would make, Sikander, is it's often, you know, when you see a mass, it's usually pretty impressive, right? Like they catch your eye, and obviously the focus on the echographer, you know, the sonographer and the person reading the study is on the mass in question. And one of the rules is to keep, you know, don't forget to do a total study and to actually look around. This notion of there can be more than one, I think is pretty important, and it can matter if you sort of miss a second mass, especially if surgery is contemplated. You know, the surgeon obviously needs to know that if there's more than one, they need to know about it so that you actually get a proper result when they go to surgery. So making sure that you aren't blinded by the light of, if you know what I mean, of the mass in question is important. I can actually remember one, a myxoma, which is in the right atrium, a large myxoma, and we sent the patient to surgery, and the surgeon removed the myxoma, and the day after the surgery, we repeated the echo, and there was still a right atrial myxoma. So we actually had the surgeon come in and look at the echo, and he said, well, I took it out. I swear I can show it to you. But there was a myxoma still in the right atrium, and in the end had to go back. So there were two. And we didn't really appreciate that there were two separate myxomas when we did the echo. And what happened, we think, is when the surgeon cannulated the heart, one of the myxomas sort of flopped down into the inferior vena cava, out of line of sight. So he took the one out that was obvious, and the one that had sort of flipped out of line of sight was obviously still there. So he had to actually go back the next day and take the second one out. So it's a really good lesson, right? Look around, make sure that you're seeing everything.
I think that's an excellent point, and thank you for sharing that anecdote. And that's well taken.
Again, it's Howard. Please follow up. You know, there are times where we'll find a mass on transthoracic, and it's fairly clear in terms of the diagnosis, and we don't necessarily go forward with the transesophageal echo. But to Bob's point about missing additional masses, etc., and for surgical planning, have you read, or what's your specific opinion with regards to, you know, do all cardiac masses require a transesophageal echo for further assessment, depending on what the management will be, or are there times where the transthoracic alone will suffice?
Yeah, so I certainly think that there's some degree of clinical equipoise. Usually, I would say that the transthoracic echo suffices, and the second modality of testing is going to be a CT scan, given the fact that it allows us to accurately assess to see whether or not there's any evidence of extracardiac extension. It's relatively quick, and we can do that, you know, fairly quickly and in an expedited fashion. But I think for certain, you know, transthoracic and certain cardiac masses that we can diagnose via transthoracic, I think a TEE, certainly if the patient's amenable to it, is extremely reasonable. You know, myxomas can be multiple, there can be small deposits, and with better subendocardial definition with TEE, I think it's very reasonable to do, although there is some clinical equipoise in the literature, particularly in the setting of a papillary fibroelastoma, particularly if the patient's asymptomatic. Doing a TEE to get a better you know, estimation of the size itself, whether or not there's, you know, mobility, if there's a significant amount of papillary fronds, do you see a thrombus on top of that papillary fibroelastoma, even though that might be difficult, might actually help you sway you from surgery one way or the other. But what I would suggest is primarily for the malignant cardiac tumors, CT probably is going to be your second modality of choice, and cardiac MRI probably not in all cases, but certain cases you might want to consider that, such as sarcomas, if you will. So a roundabout way to say that it's clinical equipoise and the patient and the clinical context will matter. And I guess that's a lot of that depends on your threshold of you know, whether or not you want to do a TEE or not.
Oh, hi, this is Chiming. Can you comment on whether we should do CT or MRI on suspicious cardiac mass, or should we just do one or both or all of the above?
So, like I said, and with transthoracic echo, oftentimes there's going to be a few diagnoses where you're able to clinch the diagnosis with a TEE or a TEE. So, for example, an atrial myxoma or a papillary fibroelastoma. I think if there is a malignant cardiac tumor, CT scans are going to be probably your second modality of choice, assessing for extracardiac extension and whether or not there's any evidence of distal metastases. And the reason I say that is because these are relatively quick. They can be done in a few minutes. And cardiac MRI, although a very, very powerful tool, does have caveats. I mean, the real-time imaging is beneficial, but you might be missing small, very mobile masses. Oftentimes, the scan itself, if you want to do a dedicated full scan for these very complicated patients, the scan itself is going to take up to about an hour and a half. So it's not going to be necessarily feasible to do in all patients, but certainly can be beneficial, particularly in the setting, for example, as I mentioned, a lymphoma, where you can obviate the need of a biopsy, or a sarcoma, where you can actually get quality images and real-time images and reconstruction to aid the surgeon in surgical planning. So I will say that it's not it's fairly nuanced, and you can't necessarily say everybody should get a CT, everybody should get an MRI. It really depends on whether the cardiac mass is metastatic, if it's benign, or if it's malignant. So that's what I would say. I don't know if Dr. Connolly has any comments on that, because I know he does quite a lot of work with the cardiac masses.
No, Sikander, I think that was extremely well said. Yeah, for practical reasons, yeah, I think the CT is probably the go-to. In certain circumstances, it may not be, but for the most part, I think the sort of question would be, you've got a transthoracic. If we think we can really easily address it and get more information, a TEE, for instance, if you think it's an uncomplicated left atrial myxoma, that would be the way to go. But if you think, it's any more complicated than that, then I do think we need a CT. As you mentioned, the problem with spatial and temporal resolution with an MRI, we've missed small, rapidly, highly mobile masses. So CT is often very useful. And then we can get a lot of important information, such as some tissue characterization aspects with the CT scan. And usually what's best done is, we reach out to Jeevan or Laura, chat with them specifically what we're concerned about. They'll then make certain it gets protocoled correctly, in which case often then they will sort of initiate the MRI if they think there's further added information that can be done. We do have a bit of a backlog with CT scan and MRI. We lost a number of technologists during the COVID and pandemic, so there is quite a long waiting list at the moment. It is a real problem. So I think practically CT probably is the way to go when you've identified that really is necessary. And I think it goes back to Bob's points of doing a very comprehensive, making certain we've looked around at the get-go, so that then I think you can say earlier on, well, TE might give us the answer, or no, we definitely want to go to CT. As a rule of thumb, I've got to say most of the time when it is more of a complex, if we think it's more of a sarcoma, if we think it's more complex, then most patients get everything, to be honest, because we don't want to be in that circumstance where we miss stuff. And the other thing I would say is, don't be afraid to, if you think it's in the left atrium, to trial a period of anticoagulation and wait and see what happens. We've all thought something's a myxoma, and then somehow it's magically disappeared on anticoagulation in someone who's got a big left atrium and it was thrombus. So there's nothing wrong with waiting. There are very, very few circumstances, unless it's usually on the right side and you think it is an aggressive sarcoma, an angio or lymphoma sarcoma, which are very, very different usually, much more aggressive. They look horrible, that you're going to lose anything by waiting a couple of weeks. So, yeah, but I agree exactly what you said, Sikander, perfect. Well done.
Thank you for your comments, Dr. Connolly.
Maybe last quick question, Sikander. Let's say it's a myxoma and you've resected it. What do we do about follow-up?
So I think typically a transthoracic echo often suffices, and following the patient along clinically, particularly to see if they develop any evidence of AV block or atrial fibrillation. I think the recurrence rate, particularly with dedicated, detailed preoperative imaging, as well as the improvement in surgical techniques, is really quite low. And so it's likely, something that we need to be cognizant of, but I don't think it's a significant clinical entity that requires too much worry.
So no echo follow-up?
Oh no, I think they do warrant echo follow-up, and I do think they do, yeah.
So I want to thank you, everyone. Thank you, Sikander, for the beautiful presentation, and also my colleagues for the insightful comments. And it's coming to the top of the hour, so let's sign off and have a wonderful day, everyone. And stay tuned for the next episode of St. Michael's Virtual Echo Round next week. Thank you.